In this episode of the Nurse Practitioner Podcast, editorial board member Victor Czerkasij discusses eczema. What is the best definition for eczema?
That's a great question. Eczema comes from an old Greek word, exene, which means to boil over. And I suppose the early application of the term eczema to those researchers looked like something was boiling over or they were scalded. And they wondered if this wasn't maybe a condition that was predominantly from the outside in. What I mean by that is maybe kind of environmental. But we've come to change the term eczema to atopic dermatitis in the last 20 years. Atopic or atopy, the word means out of place. And rather than exene, boil over, now we're pretty sure that it's a better definition to say that this is kind of an irregular, reddish, scaly patch or set of patches that presents itself overall. But to answer the question more directly as to what is the definition, it's considered a chronic disorder that has a genetic predisposition that manifests itself in an exaggerated manner. So that is where a person may have some form of stimulus to their skin, or maybe their immune system is down a bit and they present with blistering, scaling, pruritus. They have tremendous amount of excoriation. So we know that this genetically predisposed condition has this, as I said, exaggerated response of all of this, and that's where we are right now. It used to be a dysfunction of moisturization, but people who suffer from eczema now know that you can moisturize and add steroid all day long, but it can barely control it.
What's the prevalence these days?
You know, the prevalence of atopic dermatitis, or as the public still understands it, eczema, is really growing exponentially. When I was born in the 1960s, it affected about 7% of children. Today, according to the Raby Center, which is a standalone center dedicated to the research of eczema, particularly in children, a Rady Center, R-A-D-Y, in San Diego, they are now telling us that currently approximately 15 to 20%, almost 1 in 5 of the children in the United States are expected to experience moderate to severe psoriasis in their early days. So it's really growing. It's growing quick. It's kind of a frustration because it's expensive. People are suffering, and we're trying to find ways to prevent it without any serious side effects.
How common is this?
So whereas the prevalence, meaning how often it's starting, and then common, it's almost like you'd think the same question, but we're also finding that prevalence, whereas having it as a birth issue or maybe more genetic, we also find that people will experience atopic dermatitis throughout their life that weren't born with it. So we have those that are kind of the true eczema patients that have that atopic presentation throughout their life, and regardless of the weather, it could be very humid outside and they're still scratching and scaling. And then we have those that have kind of a seasonal atopic dermatitis, much like a healthcare worker like myself. I wash my hands in between all of our patients, and especially in the winter, I can moisturize quite a bit, but I'm removing that excess oil that the body produces by washing my hands, and they start to dry and scale, and we consider this a part of the atopic system, which would mean kind of something out of place. So it goes up and down in America, depending on occupation, time of year, environmental stimuli and triggers, and also we have to remember that this condition runs with others as well.
What are some of the current thoughts on causes?
So a moment ago, I mentioned that this condition can run with others. So atopic dermatitis sometimes is not a standalone. We know that it also is very common to have asthma and also food allergies or allergic urticaria, which kind of shares a relationship with food allergies. So here we have 3 conditions. Take it like 3 dogs that are chasing each other's tails in a circle. Which is the first one? Which is the second and third? We're not really sure in healthcare or research which sets off the others. We just know that if you have asthma, you're likely to have food allergies, or atopic dermatitis. But if you have atopic dermatitis, you're likely to have asthma or food allergies. And who did you go see first? Who diagnosed what? And which is the one that's considered the comorbid? They're like triplets. It's very, very difficult to determine, is this all part of one scheme, so to speak, one overarching condition, one autoimmune issue all by itself with different presentations? It's really tough to say. We also know that kids with eczema, there I go with the older term, atopic dermatitis, may also have food allergies exacerbated by diets of different kinds, and they may have to have ear tubes for draining. So really, it's quite an octopus with multiple tentacles.
What other conditions are often seen with eczema?
Interestingly, we will have other conditions that present themselves with atopic dermatitis, and it may be a surprise to consider some of them. Now, what happens if your skin is itching? Well, we scratch. If you scratch long enough, you're going to develop, if you have ethnic skin or skin of color, as we mentioned it, say that you have a background that is Asian or possibly Latino, Hispanic, or even in the African American race. If you scratch long enough, you're going to thicken that skin and darken it, or we call it post-inflammatory hyperpigmentation. In Caucasian skin, if it's scratched long enough, it will turn hypopigmented or a loss of color. And it's very frustrating to families and individuals that if your child scratches long enough, you're going to change the color of the skin permanently over time. Another issue that you might see along with this is bacterial infection. We all have bacteria on the surface of our skin. Acne, staph, strep, Pseudomonas, it all grows. But it's looking for a vector. It's looking for an area of opportunity to settle into the body. And if you scratch long enough at a spot, then you're going to have a bacterial infection. If a child has atopic dermatitis on their face and they scratch long enough and break the skin, you're likely to have secondary impetigo. Or, of course, that's being a staph infection. So imagine also your nose running on a regular basis. It's going to be very sore and red as well because we'll see rhinitis or allergic rhinitis with atopic dermatitis. The immune system, after a while, just turns to settle downwards, and they don't get sleep. So now, if you're not sleeping enough because you're scratching, then you're going to be ill more often. You're going to miss out in school. It's a real cascade. We also see more fungal infections in individuals with broken skin that scratch long enough. So this maintaining of the integument, keeping the integrity of the skin, is very, very important because it can cascade into a number of other issues that we would like to prevent in healthcare because it's better for the patient, it's less expensive for the system, and we don't have to have polypharmacy or multiple medications.
What are some of the familiar treatments?
So in treating atopic dermatitis over the years, we've seen some real breakthroughs. For example, in the 40s and 50s, we had the miracles of the first antihistamines. I think everyone remembers Benadryl and Atarax, if I can use the more familiar branded names. But we also have steroids that came out, and that was quite a leap forward. Right after we had the antibiotic explosion in the 30s and 40s, we have the first steroids. And steroids, this wonderful anti-inflammatory, were a great opportunity, but it also was shown rather quickly that you can't live on steroids. If, of course, you have them systemically, you're going to put on weight, become irritable. You can, of course, soften your bones and skin. There's a number of conditions that can result that are very uncomfortable and hard to backtrack. Now, if you have steroids in a topical form, whereas it is, again, a miracle drug, and we have 7 different strengths, 1 being the strongest, 7 being the weakest, 7 may be a hydrocortisone, or a 1 being betamethasone or clobetasol. These are wonderful, but they can also hypopigment the skin or thin the skin, called stria, and that's a permanent condition. So we have to be really careful with these limits. Fortunately, we've also had in the last few years developments of products like crisaborole ointment, 2%. We have tacrolimus, pimecrolimus, and these are topicals that are non-steroidal. But even then, if you have, for example, 50-60% body surface area, so you're going to go through a tube or a tub pretty fast. So families have also come up with what's called wet wrap therapy. And wet wrap therapy essentially is to use an over-the-counter purified Vaseline, like Aquaphor is very popular. And these are not meant to be endorsements, just so that healthcare workers are more familiar with what we're talking about. And they will put the patient in the tub, and they'll have warmish water and allow the child to soak for about 10 minutes. When they come out, they put the Aquaphor to seal that moisture in within minutes, and then wrap them in wet towels and let them sit for about half an hour. It is effective for many, many children, but I can tell you that the American lifestyle does not sometimes allow for us to have this very long process of taking care of a child on a daily basis. It's not convenient, and certainly even children get tired of doing that as well. So these are really common treatments that we have right now, and I'm glad for them, and they have proven to be effective for mild to moderate atopic dermatitis.
Are there any controversies for treatment?
So there really are some controversies for treatment of atopic dermatitis, basically because some of them have very serious systemic issues, and they can result in breakdown of kidney and liver eventually. So the problem is we may have these treatments that we're aware of, but they are not good long-term solutions considering that the condition is so chronic. So as an example, we have methotrexate or cyclosporin. These are classic immune suppressors, which can, in some patients, result in some treatment success, I should say. But methotrexate is extraordinarily hard on the liver, and cyclosporin, being an immunosuppressant generally used for transplants of organs, can really be dangerous for the kidney. So I've heard it said oftentimes, well, this product works very well for that. Well, sure. At the funeral, everybody will say, wow, this person really has great clear skin. But unfortunately, the medication took them. So that's really not a great treatment for a chronic condition overall. But I want people to be aware that I've used these products, these medications, for flares, and usually they're kind of in between time until we can get them something based on their insurance more conclusive. Another thing that people talk about, and this continues to be a huge controversy in dermatology, is bleach bath. The American Academy of Dermatology and multiple experts in eczema recommend that a quarter cup to half a cup of regular laundry bleach be placed in a tub of warm water. This a child can soak up to their neck for approximately 10 minutes. But on the other hand, I've talked to dermatologists and those of us as providers, and some say it's ridiculous because we don't know the exact mechanism, and there's limited studies, and it can cause some serious contact irritation. And let's face it, the odor is repulsive. That's why my wife doesn't like me to use much bleach at our house. But let me tell you why it might work, and this is a really good theory. There are some studies that show that atopic dermatitis could be as a result of some low-level colonization of staph that some people have on their bodies. And let's remember that there are multiple people in America, I think some of the research I've seen is maybe as many as 10%, have a resistance to staph. So you have a low-level staph colonization on the body, which may give off some kind of toxicity, which is an irritant to the skin. And that's why in some people, the bleach bath really does work. It's really worked well for just over half of my patients. We tell them don't use it more than once a week during severe flares. And I have to be honest, it may be an option. It's certainly inexpensive, and nothing ventured, nothing gained. I would probably have a child have that little bleach solution mixed a few drops in maybe a cup of water and put it on inside of their arm and wait maybe an hour and see if there's a response. If they don't have a reaction, let them try the bleach bath. And if anything, throw in a bunch of your whites and let them splash around, and you can get 2 for 1.
Are there some new approaches for treatment?
So one of the most exciting products that I've seen come out, and I'm very, very excited to use, is dupilumab. Dupilumab is an injectable biologic that is known by its trade name of Dupixent and is now approved by the FDA for treatment of moderate to severe atopic dermatitis ages 12 and older. And it also is being used in the allergy and asthma area for asthma, which goes to the heart of what I was saying earlier, is that there is some really strong belief that asthma and atopic dermatitis, along with food allergies, runs in a common circle. So this biologic, and of course biologics are across the board. People think this is a new technology, but it's not. Insulin is a type of biologic. Antibiotics are a form of biologic. I mean, essentially a biologic is a very targeted approach as opposed to cyclosporin or methotrexate, which are systemic and have some real serious side effects. And dupilumab has proven to have no black box warning, which is remarkable. And there's no labs. There's no tests. So if you're a 12-year-old and you've had steroid in the past and you do have moderate to severe psoriasis, you can have the subcutaneous injection, which is going to happen every other week or twice a month. And the numbers are extraordinary. In fact, in some studies, it shows that placebo had more side effects than the actual medication. And the side effects are generally very mild. It could be an oral herpes bout, which none of my patients have ever had, keratitis or conjunctivitis. Keratitis is an inflammation of the cornea, and conjunctivitis is an inflammation of the upper and lower eyelids. Anyway, the point is, this is practically the closest thing I've seen to a cure. While you have to use the medication, I mean, a cure would mean that they don't have to use the medication anymore, but it's just so big on improving those that are 12 and older. So the 12 to 17 group, they've got this. And right now studies are being shown that it's also effective down to 6 months old. So here we have something that all of us have been waiting for years. Now, I know it's upsetting to some that it's an injection, but just understand why. In injection, rather than oral, the medication is so fragile, the biologics, if you took it by mouth, the stomach enzymes would destroy it. But I will tell you, every single one of my adolescent atopic dermatitis patients, and I have over 125 people right now on this medication and growing, every one of them will say they'd rather not even worry about a shot, an injection, because the suffering from atopic is so great. So they don't even blink an eye. These kids have gone through it all. And I'm really happy to report that this is the new technology. I think 40% of all the new FDA-approved medications in 2019 are going to be biologics. So that's where the technology is.
Left untreated, what are some of the issues that can develop?
So atopic dermatitis is often looked at as a condition where it may be chronic, but I've seen shoulder shrugs where it's not going to kill you. I can tell you that atopic dermatitis rapidly moves into this dysfunction of the integument. And I mean, just stop for a moment to think about our skin. The skin is the only organ of the body that is an interface with the outside and the inside world. So we don't have our liver, heart, brain, lungs on display for the rest of the world. We would never know what it looks like except for, pictures of cadavers or maybe an operation. But we don't know what the inside organs look like. But we sure do know what the largest body organ of the skin looks like, and a body organ which is the skin. That needs to be taken care of. It protects us from a lot of stimulation and environmental trash from the outside, whether it's an insect bite, whether it's grime or smoke or sunshine. And it also regulates a lot of stuff on the inside, our temperature, and it just protects all the organs. It provides a cushion. If you don't take care of the front door of the house, you're going to have people breaking in. If you don't take care of the roof, you're going to have a lot of leaks. The outside is very, very important if you care about the inside. And people can have dysregulation of their temperature if your skin is compromised. If you're not, I see a lot of older patients, they allow that thin skin to rapidly deteriorate and they become ill. They get secondary infections all the time. They have this bruising effect that causes ulceration. It's awful because they're not moving so much. They're sitting in a couch and they've allowed their skin to thin from steroid use as they try to get some relief from the itching. And then I'm expected to fix it. And by then, it's very, very challenging and difficult to do. So what I would ask patients is look after your skin. One of the first things you can do is make sure if you like a hot shower, keep it cooler. If you want a hot shower regardless, make it fast. Use a moisturizing soap. Use a soap that allows you to feel slippery, not squeaky when you come out of the shower. You can't have squeaky because it takes off the last of your oil. Also, moisturize within 3 minutes of coming out of the shower so you can trap residual water inside those pores. That's just cheap lotion right there, so to speak. Which lotion do I use? Well, the remarkable thing right now is in America, we have excellent lotions. Anything that's got something called a ceramide in it is very, very helpful. Other product could be a glycerin, extremely effective, or some form of Vaseline, because it can trap moisture as well. So moisturize throughout the day, cooler shower, use a moisturizing soap. Watch out for things that have alcohol, because alcohol, whereas it carries fragrance and also color and is very pleasing to some people, also dries the skin. So we want to make sure that we avoid that. One other product I might mention besides glycerin and the others or ceramides is using dimethicone. Dimethicone, it should be a very good ingredient in many, many over-the-counter products because it doesn't absorb into the system, and it's also wonderful to fill in the gaps, so to speak, in the skin. I can just say that long-term care of the skin will result in good integrity, and for people who are extremely sensitive, atopic dermatitis, of course, is where they're very sensitive. They'll just feel better overall. If you're not scratching your skin, then you're going to be happy.
What does the future hold for treatment of atopic dermatitis?
So right now with atopic dermatitis, we're trying to figure out why we have the increase in the last 50 years in America in particular. Why is it that what we normally saw, less than 10% of the population, is now doubled, and it continues to increase? So where are we going? How can we prevent whatever it is that's happening? I can tell you that we are closing in, and I shouldn't say this myself personally, but speaking on behalf of researchers in America and that I'm aware of and those working on the healthcare lines, I find that individuals who follow a better diet, and I really do believe that our prescription aisle should be the food aisle. We can do a lot more for ourselves in terms of diet through the research to not irritate. And two things I find that really, really stimulate atopic dermatitis breakouts, as well as the research supporting this, is dairy, limiting dairy, as well as sugar. Let me tell you why. Sugar is highly inflammatory, and any of the recent studies in the last 5 years from the World Health Organization down will tell you we really don't need more than 2 cubes a day of sugar. And yet a can of soda can have 35 cubes by itself. And it's not unusual for some people to have 3, 4, 5 cans of soda, as well as all the processed foods we eat that have sugar. Sugar is highly inflammatory. In individuals who have a sensitive system that can, as in atopic dermatitis, have kind of an exaggerated response, really, if we limit sugar, we find that it's much better for us. And that would be down the line with obesity or diabetes or stroke or even cardiac. But we find that folks who limit sugar can have an improvement in their atopic dermatitis. The other one is dairy. And dairy, I can ask our listeners, what is the only mammal in the entire world that never gives up on breast milk? Well, the answer is the human being. Every animal has breast milk from their mother for a certain amount of time, then moves on. But we like the taste and flavor so much, we add sugar. And then also we find that taking it from a cow, a sheep, or a goat, this milk, which was meant for an animal to grow, we take it to ourselves, and we'll concentrate it, for example, in cheese. But there are a lot of dairy allergies out there that produce excess mucus, and that, of course, stimulates the ear tubes that we find. Also, some folks will have an asthmatic response, as well as, we're not sure the exact mechanism again, but we find that people with atopic dermatitis, it's almost an irritant. And if the less irritation we can have, and dairy being one, I think the better we'll do. So to answer your question there at the beginning, what the future holds, we're finding out that diet is playing a huge role outside of the general hydration and care, as well as some of the biologics. So coming all together, I think that maybe it's something to consider with our patient population. It's a good discussion of prevention.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.